Hello everyone and welcome to another deep dive session with PEG Practical EKG Academy. Today we're going to be discussing this 12-lead ECG, and if you've gone to the rapid session, this is a deep dive session, so if you've gone to the rapid session, feel free to skip through the first couple of minutes, but we're going to break this down and start off with a single lead. Before we get to it, I want to remind you, work on your method, no matter what it is. Doesn't matter if you're taking somebody else's, just have something handy. I'm making this video and I'm pretty tired at the moment, so my eyes are playing tricks on me, and I'm really trying to utilize my method at the moment. Okay, so somebody throws this strip at you, right? With any strip, rhythm strip, right? Single channel, the best you can hope for is rate and rhythm. And anytime somebody says, rate, your mind immediately should be going the rate of what? Now, sorry, I brought that up a little too early, but I want to, this is looking pretty aggressive. Okay, it's a very aggressive looking ECG. It's fast. The R2R is irregular, and again, I'm doing this as I was tired. When I was first looking at this, I didn't want to look at it. I really didn't want to make this video, but I couldn't leave it alone. So baby steps, right? Going back to baby steps. So first thing I did is I started looking at the R2R. Typically when you look at R2R, I like to go from the onset of whatever you're talking about. But the problem is, if you take a look at this QRS, you can see it coming off the baseline nice and clean, but here it's not so clean, right? So what I did is I went up to the peaks. And you can do that. That's frequently done. Not a huge deal, but sometimes it can trick you. And it can trick you to the point where you make a completely wrong diagnosis. So be careful when you measure things out, right? So I just want to kind of measure things out. And you can see here that this is not, this is an irregular rhythm, right? Every so often you get the same R to R, but that, if you don't have consistency there, it only supports the fact that you have an irregular rhythm, which immediately makes me think about atrial fibrillation. Going to, well, just looking at the QRS, I want to take a look at the QRS. It seems pretty narrow here, but I'm going to be taking a closer look at it when we get more leads. One rhythm strip off of a single channel, is that going to confirm that this is indeed, 40 or whatever, 35 milliseconds long? Absolutely not. Absolutely not. Okay. So, as far as the rate goes, I can't get anything off the baseline. The baseline is complete garbage, right? But R to R, since this is all irregular, what you're going to have to do is you're going to have to average it out. Now, this strip is 10 seconds long. Okay, this strip, it's a typical 12 lead, so it's 10 seconds long. So if I had 6 of these strips, that would add up to a minute, and then it would be easy for me to grab my per minute, beats per minute rate, right? So here I already counted out these QRSs, and there's 31 of them. Since this is 10 seconds long, right, I'd need 6 of these to get a rate per minute. So 31 times 6 will give me 186 beats per minute. So that's being averaged out, right? It's not going to be 186 everywhere. That's the average here that we're looking at. Now I'm going to move on. I want to see what's going on here. So when we add a couple more leads in here, we were looking at lead 2, then here we have V1, and we also have 1. So we have a right chest lead and an excellent lead for P waves. And we have lead 1, which is a lateral lead or high lateral lead. Now, first thing that really stands out to me is lead 1. Okay, this to me screams atrial fibrillation. Fine atrial fibrillation. There's also coarse atrial fibrillation, which is something that I'm kind of thinking about when I look at lead V1. And the reason for that is, look at this. Look at this here. You know, is this an ectopic P wave? Is this a regular P wave? You know, what is going on here? But there's definitely something present in front of every QRS. Now, is this just a culmination of the wavy baseline, and every so often you get a bigger depolarization, be it positive or negative? I'm not sure at the moment. So far, I'm still stuck on atrial fibrillation. So I'm going to move on to the 12 lead. I want to see what the 12 lead says. So when we get to the 12 lead, right, I'm just going to take a look at the axis of depolarization. It's just a habit I have. So upright in 1, upright in 2, 3, it's difficult to say. Maybe it's upright, maybe it's not, but AVF is. And this is enough to say to me that, let's see here, right? If you were to look at lead 1 and AVF alone, so here's lead 1, it's upright. Here's lead AVF, it's upright. We're in the bottom right quadrant, so this is a normal axis of depolarization. Again, I'm doing this, I'm tired, so I'm just gathering data, as much data as I can. And hopefully that will help me in figuring out what it is that I'm looking at here, right? Now, AVL is upright, so that's good. AVR is inverted, which is as expected. Moving over to the precordial leads, I'm looking at R wave progression here, and the R wave is barely visible, but it does transition from, a predominantly S wave to this sort of equiphasic state in V4. So the transition is happening really in V4 itself, a little bit late, but it's not per se indicative of anything grave at the moment. Now, while I'm here, I'm noticing this. I'm noticing this ST depression. And let's zoom in here. So see how the baseline, the baseline is, for example, well, I'm going to move up a single lead here. So the baseline is right there, right? Because the QRS is coming off of the baseline, right? And then we get this ST depression, that is the ST segment is below the baseline. Look at this over here. This might be an even better example. I didn't even see it. I might just stretch these guys out a little bit. Now, so the reason why I say this is ST depression and not just a waveform, this ST depression is present in all of these beats. So look at this. This is V5, right? It's present here, it's present here, it's present here, it's present here, it's present here. If we move up a lead, same thing. Look at this. This would be your baseline roughly. Well, here it is. And then you have this depression here, roughly 2 box. Well, a little over 1 box. 1 box is a good guideline. It's a good rule, actually, to have. So anything bigger than a box is an issue. But oftentimes I will react to things that are even, half a box. But that's a different lesson. So here we definitely have some sort of ST depression present. If we move over to lead V6, again, same thing. Grabbing it right here, like look at this. It's exactly 1 box, really. So something is going on, but it's happening in every single beat. That's the key, okay? It's happening in every single beat. Versus if you were to take a look at here at lead 1, maybe you have a little bit of depression there. Maybe you have a little bit of depression there. Maybe, right? It's a big, big maybe. Lead 2, you have a slanted slope here. We have, definite ST depression. So I'm not sure what's going on here. This is not confirming anything for me. It is raising my suspicion. However, over here, it's clear as day, right? There's a little bit of ST depression. Now, with high heart rates, right? you have your maximal expected heart rate for any age group is 220 minus the age group. So if somebody's 20 years old, maximum their heart rate should theoretically, under normal conditions, go is 200 beats per minute. However, sometimes you will see it go way faster than that. So here I'm just kind of gauging this. I don't know anything about this person. I don't know who this came from. Somebody sent this to me. So I'm just kind of going through the ECG. But I'm assuming if this indeed is atrial fibrillation, this is probably not a younger person. Okay. It's difficult to see atrial fibrillation in somebody that's 20 years old. I have seen it, but it is extremely rare. Okay, where am I going with this? Oh, yes. So ST depression. So there's something known as tachycardia-induced ischemia. And what that is, wait, hold on, let me see, right here. So if we, take a look at the heart, you get your blood supply. So off of the aorta, right? You have your left main and right coronary artery coming off of it, and it supplies the rest of the heart. It supplies the heart. Well, if the heart rate is so fast that the ejection fraction has been compromised, maybe not enough of the blood is getting to these regions. And here we're talking about leads 4, 5, and 6. So here's your V5, V6, V4. I don't know where the V4 disappeared. Oh, here it is. So we're talking about this region of the heart, or your left main. Now, I'm going to leave it at that. I don't want to get too specific about that, because figuring out which artery is in play, it's an art form in itself, and you really should be precise about that, right? Or at least strive to be. But we're looking at the left side of the heart, right? Everything is inverted. Here I'm pointing to what seems to be the right side, but it's actually the person's left side. So the left lateral side seems to be diminished in oxygen, and that can sometimes happen during even sinus tachycardia. So sometimes you will have sinus tachycardia, and during the tachycardia you will have some sort of ST depression. Now, what needs to happen is this heart rate needs to go down. And when the heart rate goes down, if this ST depression is still present, if it doesn't go away, then you have a problem. Then you have ST depression in V4, V5, and V6. And you have to start looking for perhaps reciprocal changes in other leads to see if there's any ST elevation somewhere. Or you're going to have to continuously monitor this patient and see if this ST depression eventually starts turning into ST elevation. Okay, so this fast heart rate becomes almost irrelevant compared to the findings you see in V4, V5, and V6. That's the big red flag in this ECG. Now I'm going to go back to, and I'm just going to box this up here so you really focus on that and you don't forget it. Okay, so you see something that's fast, it's irregular, you label it atrial fibrillation and you move on. No. Wait. See if there's anything else going on. Again, this rate needs to go down for you to see if this ST depression goes away. Okay. Now, as far as the rhythm itself, okay, I'm going to, let me go back to this screen over here. I'm going to zoom in a little bit. If we're looking down here at lead 1, this looks like straightforward atrial fibrillation to me. However, when we take a look at V1, which is typically the best lead, if you're looking for P waves, right, that's the best lead to look at most of the time, okay? But look at this, you get a pretty solid, what looks like a P wave, right? When you're looking at ECGs, there's stuff you can reference to in the any sort of reference material pretty easily, and you can figure out what it is. And then there's this pattern recognition, which emerges with experience, with time, okay? And it allows you to better filter necessary and unnecessary information. It's really you training your eye and your mind to work in unison, to figure out more easily what indeed is going on. Look at this up here. This is all making me wonder. Again, I'm tired. I'm doing this. I'm very tired, and I haven't really prepped ahead. I never really prep ahead too much with these videos. I just kind of go into it so you can get the experience. If I make a mistake, you get to see what it's. I'm not trying to shy away from anything here, but here's the point I'm trying to make. So if this indeed is atrial fibrillation can be split into coarse atrial fibrillation and fine atrial fibrillation. Fine atrial fibrillation looks more like down here. You're barely going to see anything on the baseline. Coarse atrial fibrillation, you're going to see larger depolarizations on the baseline. Now, coarse atrial fibrillation easily mimics multifocal atrial tachycardia. So this is tachycardia that's coming from different focuses within the atrium. So different focuses in the atrium could be setting off this tachycardia. And I'm sorry, I have this up here for a reason. So this is atrial fibrillation. You get these micro-reentrant circuits, right? It's typically displayed as a bunch of irritated cells, and that is true. The only missing piece of information is they form these small micro-reentrant circles. Circuits. With atrial flutter, for example, you'll get one big one. With atrial fibrillation, you'll get a bunch of little ones. And then they send the signal, they propagate the signal down to the AV node. AV node is supposed to slow that signal down. However, here the AV node is not slowing the signal down. The AV node is letting most of this signal pass through at a very high rate, which is a problem, which is indicative that, the AV node may not be functioning as well as it ought to. Okay, where was I? So to try and figure out what this is, to be 100% sure, it may be difficult, just looking at the CCG. But if you are performing, if you are the one that's capturing the CCG and you're looking at the screen, what I would do, see this little break here where we caught this P wave? You might get more of these breaks and they might be longer. So you just let the machine run while the patient is hooked up and you're hoping for a bigger break. Now imagine if you had a break, for example, from here to right here, and that baseline came across, looking something like that. You'd be 100% sure you're looking at atrial fibrillation. However, you let that play out and the baseline starts doing something like this. Now you're dealing with probably atrial flutter. Or what if, you get something like this? Now you're looking at multifocal atrial tachycardia. But you get the point, right? You have the tools in front of you. Don't cut yourself short. Don't be happy with just getting the ECG done and passing it on. You have the tool in front of you. Use it to its maximum potential in order to make your job easier. Okay? Now, we talked a little bit briefly about that. So this ECG, right, you let it run to try to definitively figure out if indeed you're looking at coarse atrial fibrillation, fine atrial fibrillation, perhaps atrial flutter, or multifocal atrial tachycardia. These are all possibilities on the CCG. Now, multifocal atrial tachycardia, even though V1 seems to support that, just the morphology of it. I am not inclined to call this multifocal atrial tachycardia for one and only one reason, which is not a great thing to do, but multifocal atrial tachycardia tends to be a little bit slower. Okay, this is 186, let's say 190. Multifocal atrial tachycardia typically is, 100 to 150, but it can go as high as 250. It's possible, but if this was going at 250, you wouldn't be able to see the baseline anyway. You would need those breaks. These breaks are golden. When you're talking about fibrillatory or chaotic rhythms, better said, make sure you do yourself a favor and you find these breaks. You look for these breaks. This is a small one. And this one also kind of cancels out atrial flutter for me. I'm just not seeing the pattern that I was expecting. So we're left with fine and coarse atrial fibrillation. This indeed could be coarse atrial fibrillation. Coarse atrial fibrillation, well, it tends to be a little more coarse and a little more consistent in that coarseness, and it tends to show up in more than one lead. Here, this is looking more like fine atrial fibrillation. Is it going to be a huge deal whether it's coarse or fine? Absolutely not. Maybe later down the line to an electrophysiologist or a cardiologist perhaps, but just for the sake of labeling this rhythm and passing it on or inputting this information into your diagnostic chart, if you were to call this atrial fibrillation, that would be just fine. Now here's the important thing. You should, obviously, it's from the rate the person is going to know, but add this with RVR, which stands for rapid ventricular response. This means that the AV node is not slowing down the signal. So the AV node is not slowing this down at all. There could be something wrong with the AV node, which then starts begging the question, right? The AV node is supplied by the RCA. There's a little shoot off of that. That's not the only thing that necessarily supplies it, but that's the main thing. So you might be looking at, perhaps a potential issue there or something else is going on. But RVR, and I'm sorry, there's a lot of R's here, but RVR tells you that, the AV node needs a little help. So again, label it as atrial fibrillation, fine, of course, doesn't matter. I just wanted to discuss these briefly. Watch for these breaks. Try to capture them on an ECG. They are extremely helpful during diagnosis. And do not forget about this ST depression. Okay. Hopefully you enjoyed this. Hopefully it was a little more informative than just the rapid version. The rapid version, we just kind of flew through it. Thank you for joining us, and we'll see you next week.